I'm here to give you all a dementia update. So dementia. In 2010, there were 35.6 million people with dementia worldwide. The costs in lost time and healthcare costs were $604 billion. If we don't change things, 415.4 million people will have dementia by 2050. Research is hot and heavy on the topic of dementia, specifically focusing on Alzheimer's disease, how to prevent it, and what to do about it. We're not there yet, but we do have more knowledge than we did 10 years ago. So I want to review a little bit about dementia and what we're looking at. So to understand dementia, dementia is the brain is not functioning appropriately. And as opposed to a stroke, where the brain is not functioning because one part of the brain has died, this is an insidious change, usually slowly progressive. And it's not always, it doesn't usually affect motor skills or speaking skills, although it can. The cognitive domains are affected are much more about the things that make us people and the things that help us to interact with our environment. Different cognitive domains include the acquisition and memory aspects, being able to acquire and remember new information. Symptoms of a dysfunction of this domain include repetitive questions. Reasoning or handling of complex tasks, being able to cook supper and make sure that the green beans are ready at the same time as the roast. Being able to balance the checkbook or remembering and paying bills and not having checks bounce all the time. Managing finances are part of the executive or reasoning functions. Visuospatial function, this is what helps us prevents us from getting lost in familiar areas. It also helps us look at a comb and know how to use it, or look at an object and understand what it's supposed to be for just based on the shape of that object. Language function, difficulty thinking of common words, difficulty getting the words out. And personality and behavior, sometimes coming out as apathy. All of these are cognitive domains that can be affected in dementing illnesses. So what is dementia? Dementia is a disorder that interferes with the ability to function. So I can't really remember that guy's name that I go bowling with all the time, but you still get along just fine at work. You can complete all of your ADLs. That's not dementia. It is a decline from the previous level of function. So if you were never able to remember Bob's name from the bowling team, then that's not necessarily an indicating factor either. It's a decline. It's also a disorder that is not explained by delirium or a major psychiatric disorder, and you have cognitive impairment that is seen on history and objective exam. Now this is very important. The history has to be not just from the patient, but also from a knowledgeable informant, okay? So I have people show up in my office for a dementia evaluation and they're by themselves. That's not adequate for a true evaluation of dementia. It's also needed that that we have someone else there, whether it be the spouse, although sometimes the spouse has memory difficulties also, or it can be a neighbor, it can be a child, it can be anyone, as long as that person has enough exposure and knowledge of the person in question to provide adequate history. So what is Alzheimer's disease? Alzheimer's disease is the most common form of dementia. It has an insidious onset that lasts at least 6 months. There is worsening cognition by report or observation, and at least 2 cognitive domains are affected. The most common is amnestic, so memory plus one other domain is affected. A lot of times we'll see memory and visuospatial, but sometimes it is word finding, sometimes executive, sometimes visuospatial plus a non-amnestic category. So, but by far the most common type of dementia is the amnestic type of Alzheimer's. So what are the warning signs? 10 warning signs of AD as presented by ALZ.org include memory loss that affects job skills, difficulty performing familiar tasks, problems with language, disorientation to time and space, poor or decreased judgment, problems with abstract thinking, misplacing things, changes in mood or behavior and changes in personality, the loss of initiative, just not interested in doing the things that he or she was interested in doing before. What are the criteria for saying, well, this is not Alzheimer's disease? If we see early difficulty with walking, if we have known history of seizures, or if there are seizures that are associated with some of these mental status changes, if there are early behavioral changes and significant behavioral changes out of proportion to the memory changes, that's when we start to look at other disorders, other types of dementia. If we see hemiparesis, which is focal weakness on one side of the body, sensory loss, visual field deficits, those indicate that maybe stroke is playing more of a role than Alzheimer's is as far as the memory difficulties. Early EPS, sorry, this is from another talk, EPS are extrapyramidal symptoms, so symptoms that are similar to Parkinson's disease. Stiffness, rigidity, shuffling gait, those kind of things make us think of disorders other than Alzheimer's disease. Other disorders that can certainly explain Alzheimer's type of symptoms include major depression, non-Alzheimer's dementia, cerebrovascular disease, toxic or metabolic abnormalities, and MRI changes of infection or stroke. So infection and stroke can both mimic Alzheimer's types of symptoms. So I mentioned the term mild cognitive impairment a little bit earlier. What is mild cognitive impairment? It is a limitation of a single cognitive domain that doesn't really get in your way all that much. So objective and subjective findings are that memory is not the way that it should be, and it's a little bit worse than it should be necessarily for age. But it doesn't affect your work, doesn't affect your activities of daily living. This also requires reports from a patient as well as a knowledgeable informant. And these people we follow regularly to see if there's any change in their memory examination and their memory testing, because these people can progress to Alzheimer's disease. There is argument, but some studies report up to 50% of these patients will progress to Alzheimer's disease. Some studies report less than 10%. So it's very variable, but it definitely needs to be followed. There is no evidence that screening for mild cognitive impairment is helpful in asymptomatic individuals. So just because mom has Alzheimer's doesn't mean you need to necessarily get screened for mild cognitive impairment. Now, that being said, there are all sorts of studies going on family members of Alzheimer's, of patients with Alzheimer's. So if you feel the need to get involved in one of those studies, by all means. But unless you're having memory difficulties yourself, then there's not really very much reason to go on and have yourself evaluated. Treatment in the MCI stage is questionable, but in general, the idea is that we treat these patients with the same medicines to try and prevent progression of Alzheimer's. So these acetylcholinesterase inhibitors like Aricept or Exelon, and in some patients, Namenda. Now, it's harder to get insurance to approve a non-generic drug like Namenda for someone who just has MCI, but those are the kind of what we look at. And the acetylcholinesterase inhibitors, I think, are much more commonly prescribed for MCI than they were maybe 5 years ago. MCI is a prime target for research, so there's definitely a lot of interest in trying right now. Once the cells that have been damaged by Alzheimer's are damaged, there's nothing we can do to get them back. So research is trying to go back and trying to identify Alzheimer's as early as possible so that we can try and stabilize the brain and prevent the loss of those neurons. So that's kind of where research is focusing, and MCI is of great interest in those kind of research studies. So, what mimics Alzheimer's? What is there that we can do? And we can't necessarily reverse all of these disorders, but we can at least treat them and try to deal with the symptoms. Hypothyroidism is one important symptom, one important disorder that contributes to memory difficulties, B12 deficiency and thiamine deficiency. Normal pressure hydrocephalus that has a 3 symptoms the memory difficulties, walking difficulties, and urinary incontinence. Subdural hematoma, either acute or chronic. Depression, the effects of drugs, the effects of infection, paraneoplastic syndromes, and seizures. All of these can look like dementia at different points in time. And all of these need to be, depending on the patient, they need to be evaluated and discarded as possibilities. So what other types of dementia are there besides Alzheimer's? Vascular dementia is probably the most common beyond Alzheimer's, and there are those who think that these are not two separate disorders so much as a spectrum where both will be involved in everyone with Alzheimer's disease. Frontotemporal dementia, it has two different variants, one that affects behavior more, which is the frontal variant, and another that affects language more, which is the temporal variant. Dementia with Lewy bodies and Parkinson's dementia have more of a Parkinsonian symptoms to them, so difficulty walking and sometimes hallucinations. Progressive supranuclear palsy is also in the category called Parkinson's plus syndromes, which has a Parkinsonian flare, early falls. Primary progressive aphasia affects language more than anything else, and Creutzfeldt-Jakob disease, which can run in families and can be acquired, but is much more rapid in onset than Alzheimer's dementia. So if you're worried about memory, talk to your doctor. Start the process, because while Alzheimer's we can't fix the damage that has occurred, we do find that getting you on medicines early and ruling out all of these other things is certainly essential in appropriate treatment. The tests that I will always order or make sure have been ordered when someone comes to see me: standard blood work, so CBC, serum electrolytes, CBC is a complete blood count, serum electrolytes, sodium, potassium, glucose, BUN and creatinine, checking the renal function, B12 levels, liver function tests, and thyroid function tests. I have to make sure that all of these are appropriate before I go down any other roads or any other diagnosis. And I am a little bit biased, being a neurologist. I like the brain. I like looking at the brain. I think everybody deserves at least one MRI unless they have a pacemaker, and hopefully within the next 5 years, even if they have a pacemaker. So, but brain imaging is also very important. CT or MRI, make sure there's not something going on in there that we are not aware of. We have the technology, we might as well utilize it. Other tests that you may expect. These are not things that I order on everyone, but this is part of my repertoire, as it were, of testing that I will order depending on what the patient, the presentation of the patient and the complaints. So neuropsychological testing, which those cognitive domains that I mentioned before, neuropsych testing, whereas I will do a 10-minute bedside test on my office exam, they take that and expand it out into 2, 4, 6, 8 hours worth of testing to really get down to the nitty-gritty of what parts of your brain aren't functioning right. An EEG, if I'm suspicious of seizures, if there is some fluctuation in the mental status. A sleep study is also another essential test. Sleep apnea is an under-recognized and under-diagnosed cause of memory difficulties. And so I have a low threshold for doing something called an Epworth Sleepiness Scale and evaluating someone for sleep apnea. Spinal tap, this I usually save for some of our younger population and dementias that are specifically rapidly progressive. A PET scan, SPECT scanning, and gene testing. I almost never do gene testing because once we find the gene, there's nothing we can do about it. Give us a few years, and if we have gene therapies, if we have something to do about the gene testing, then that's great. But why run an expensive test when it's not going to change anything that you're going to be able to do, is my personal opinion. So how do I get dementia? There are genes that are associated with Alzheimer's disease. Presenilin, amyloid precursor protein, in chromosomes 21, 14, 19, and 1. Chromosome 21, many of y'all might be familiar with trisomy 21 or Down syndrome. With that extra dose of chromosome 21, people with Down syndrome, as they get older, are much more likely to experience Alzheimer's disease at an early age compared to the other population. So that's just one of the ways that we discovered that chromosome 21 was important in Alzheimer's, was people with Down syndrome are living longer, and we're realizing that that's associated. The environment can contribute to memory problems as well as worsening dementia in someone who has dementia. So vascular risk factors, cerebrovascular disease, depression, head trauma, toxins, and a lack of activity. All of these things we have found contribute to the risk of progression of the illness. So how do I prevent dementia? Well, one thought is that we can bulk up on our cognitive reserve, and I'll explain what cognitive reserve is in a minute. Control your risk factors for vascular disease, more important now than ever. Mediterranean diet, physical exercise, avoiding depression, and reducing stress. So all the things that your doctor tells you you need to be doing anyway, they also help prevent dementia. So cognitive reserve. This is a theory that came from the nuns. Dr. David Snowden worked with a group of Catholic nuns. His book, Aging with Grace, discusses some of his findings. So the nun study, one of the things about Catholic nuns, and I'm not sure if it's all Catholic nuns or just the ones that he studied, but they are required to write an autobiography. And they found that with this journaling, this autobiography, the more complex it was, the less likely they were to develop Alzheimer's symptoms. Now, this particular group of nuns donated their bodies to science, and so we got to examine the brains of all of these nuns. And so the nuns were examined for symptoms of Alzheimer's, the brains were examined, and we looked at their journals. And the more complex their journals were, the more complex their autobiographies, the less likely they had symptoms of Alzheimer's disease, even if there was significant Alzheimer's pathology in their brains after they died. So that developed the theory of cognitive reserve. Basically, keeping your brain active can prevent symptoms of Alzheimer's. Now, which came first, the chicken or the egg? Was it the cognitive activity, the complexity of life that helped prevent the symptoms, or was there some other thing that was related to both? Was there some genetic factor that made them both resistant to the cognitive symptoms and made their lives more complex? We don't know the answer to that, but it means that there's no harm in looking for challenges and trying to maintain complexity of your mental life. Consistent challenges and stimulation can stave off dementia is the theory. There is no guarantee to any of this, of course. So the more you use your brain, the better you will be able to deal with the twists and turns that age throws at you. You can use level of education, complexity of the job, leisure activities to estimate cognitive reserve. We have not found a great estimate for this yet, but all of these things can play a role. So what can we do? Mental exercises, Sudoku, crossword puzzle, cards, reading, just maintaining that mental activity. Brain training games can be helpful as well. Continue to do stimulating and challenging things. Learning something new every day. All of these things can contribute to maintaining that cognitive reserve and trying to grow those neurons. So what else can we do? Well, we've also found that social interaction is really important. Personal relationships. As social creatures, and yes, we are all, by nature, humans are social creatures. We keep each other healthy mentally by maintaining those interactions. My husband found a study that said that the thing that is going to extend the life of a man is getting married, and the thing that extends the life of a woman is her girlfriends. So there's something to be said for that social interaction that we all need. So, cerebrovascular disease. This is another very important topic that is often missed. This is the picture of a brain of somebody with high blood pressure, high cholesterol, diabetes, little bitty scars. We all get these as we age. I'd be willing to bet that anybody with, almost anybody with dementia especially Alzheimer's disease, has a brain that doesn't look too dissimilar from this. But the question is, how big a role do these little scars play in the memory difficulty and the difficulty that you have in maintaining as normal a life as possible? So a recent position paper from the American Stroke Association warns people about the association between vascular disease and dementia. Snowden noticed that increased tiny strokes increase the chances of developing dementia. Whitmer did another study, and he showed that hypertension, smoking, high cholesterol, diabetes, all of these increase the risk of dementia 20 to 30% above the normal population. A recent article by Marchant and colleagues, actually, is going to be published in April, looked at the difference. We now have imaging studies that can look at amyloid, which is a protein that is deposited in the brain of dementia patients, and an MRI that can look at how many of these white spots there are. So Marchant looked at the difference between the level of amyloid and the level of white spots and found that a patient is more likely to progress as far as memory difficulty based on the level of white spots than they are the level of amyloid deposition, which kind of flips all our thinking on our head, because we thought that dementia was the primary process, but now there's evidence coming out that, you know what, maybe it's those stroke risk factors that are the primary process for people getting worse when they have dementia. So what else can we do? You can control your stroke risk factors. I will sound like a broken record. High blood pressure, diabetes, high cholesterol. You've all heard it from your primary care. You need to control these to try and prevent progression of dementia. Quit smoking. I will say it again. Quit smoking. If there is anybody in here who still smokes, and the threat of lung cancer doesn't scare you, the threat of strokes doesn't scare you, maybe the threat of dementia and losing yourself will. Quit smoking. Treat atrial fibrillation, stroke prevention for atrial fibrillation. That is very much a complex decision that has to go through you, primary care cardiologist, and sometimes neurologist, and a daily aspirin if it's appropriate. So what about diet? Is there something that I can eat to prevent dementia? Well, the Mayo Clinic suggests that a Mediterranean diet is one of the most healthy. Plant-based foods, fruits, vegetables, whole grains, legumes, nuts, all of these things. Healthy oils, olive oil instead of butter, spices instead of salt. Fish or poultry at least twice a week, rarely red meat and sweets. And avoid significant carbohydrate loads. Avoid processed foods. Try to eat as healthy as possible. Eat real food, and you're going to be better off. Antioxidants. Are there antioxidants that I can eat? Well, personally, I think the list of antioxidants looks really tasty, so I would recommend adding these to your diet as much as possible. Most types of berries, pears, plums, oranges, artichokes, asparagus, red cabbage, sweet potatoes, nuts, dark chocolate, excellent. Teas, coffee, and an occasional glass of red wine, all of these things in moderation are excellent sources of antioxidants. Vitamins, there's nothing really to support these just yet as far as preventing dementia risk. Now, if you are deficient in vitamin E, vitamin D, or B12, those certainly are things that you need to replace, but extra doses of them have not been shown to be particularly helpful yet. Research is ongoing. Ginkgo biloba theoretically should be helpful. St. John's wort is an antidepressant that also might be helpful in dementia, but be cautious because the particular type of antidepressant interacts with several other medications. So any vitamins or alternative supplements that you're taking, your primary care and whatever doctor you go to need to know about those. Be sure to tell your physician about supplements. And recognize that just because the FDA does not monitor supplements does not mean that they are safe. Look for quality supplements. U.S. Pharmacopeia is one monitoring board that is helpful as far as trying to make sure that the supplements that you're getting are the supplements that they are supposed to be. So what else? Well, there are lots of other aspects of good health and well-being that we, in the modern day and age, tend to not pay attention to. Keep your mind, your psyche, and your body healthy. Relaxation exercises, being able to take that stress and put it somewhere else. Avoid excessive stress. In other words, if Sudoku drives you nuts, it's not going to help your cognitive reserve very much. Physical exercise, get out and walk, get in the sunlight, walk, start 5 minutes a day, and then just gradually increase that until you're walking for 30 minutes a day. Especially if you're retired, it's a great way to spend 30 minutes. If you're not retired, walk back and forth during the lunch hour. I mean, as much walking as you can, getting the sun on your face, it has a huge impact on mood, it has a huge impact on your well-being. Study after study has shown that the longer that you are mobile, the longer that you are walking, the better off you're going to be. And you're not going to stay walking for very long if you don't walk. So please get out there and get some exercise. Get appropriate amounts of sleep. For all the ladies in the crowd, maybe men too, but the easiest way to lose 10 pounds is to make sure that you get at least 7.5 hours of sleep a day. So the adequate amounts of sleep are helpful in lots of different aspects, but especially sleep deprivation can contribute to memory problems, word finding difficulty, and things like that. Be on the lookout for depression. It is under-recognized, especially in East Texas, but depression can come about as memory difficulties, it can come about as rage, it can come about as more than just feeling depressed. So be on the lookout for those kind of symptoms in yourself and your loved ones. And live with purpose. The thing that I hear the most often from some of my older patients is, I don't feel like I have purpose anymore. So it's hard, but continue to try and find that purpose that is going to complete you, that is going to help you. Isn't it too late for me? I'm already 80. It's too late. I've already got dementia. It's too late. The benefits of these changes are certainly more apparent if you start earlier, but it's never too late to start living a healthier life. In general, the longer you stay mentally and physically active, the better off you are. So patient assistance, where can we go to get help for diagnosis, or once I have a loved one with Alzheimer's, where can I go to get help for that patient, or caregivers? Alzheimer's Alliance of Smith County is a huge resource. Alzheimer's Association, UCF Memory Center has a lot of good material as far as resources and patient education programs, and the Mayo Clinic always has reliable information as well. Caregiver stresses, just to end on the same note, the 36-Hour Day by Mason Rabins is a very helpful book as far as trying to help you understand that you're not alone in this fight. And it is a fight. It's a fight every day when you're taking care of a person with Alzheimer's. But everybody faces different challenges. Caregiver.org has some good tips and tricks as well. Home health, when home health comes in, getting a home health company that's able to focus on palliative therapy instead of curative therapy. Again, we are not in a place where we can cure the damage that has happened, but the point of all of this, therapy for everybody with Alzheimer's is to try and get their last years, however long that is, to be what they want it to be and to be as comfortable as possible and to maintain a sense of dignity and a life that's worth living. So focusing on the palliative therapy and trying to prevent some of the acting out and some of the irritation that can happen in the home is what home health needs to be doing. Address sleep and behavioral issues early. A lot of times people with Alzheimer's will get their sleep cycles flipped and sleep during the day and be awake at night, and this drives the entire family crazy. So get this addressed early and do what you can to address sleep issues. Be aware of burnout. Feel it when it's coming on, all those who are caregivers, and recognize it sooner so that you can say, I think I need a day off. I think I need to talk to the Alzheimer's Alliance and see what I can do about respite care. I need to find outlets because this is a marathon and not a sprint. And y'all can't be doing this alone, or you can. It's a lot less healthy if you're doing it alone. Be prepared for hard decisions. Preferably, the patients can be a part of those decision-making process, but making sure that things are in place like a living will. Decisions have been made as far as, well, mom would rather die than go into a nursing home. Well, is that really truly the case? Because a lot of times our nursing homes have memory care units, and assisted living has memory care units where they have a staff who is specially trained to deal with some of the issues. And it's really not that much different than just living in an apartment. So just be aware that the decisions and the difficult decisions are there, and the sooner you make them, the better you'll be better prepared to deal with them when they do arrive. And these are my resources.